Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the Myeloproliferative Disorders chapter of Hematology and Transfusion Medicine Board Review Made Simple. Myeloproliferative disorders are a phenotypically diverse group of stem cell-derived clonal disorders in which one or more cell lines of myeloid lineage proliferate. Classification is 1. Chronic myelogenous leukemia, which is BCR-ABL positive, translocation 922. Chronic neutrophilic leukemia may be BCR-ABL positive. Next, Polycythemia Vera, 90% will exhibit the JAK2 mutation. Next, primary myelofibrosis, some will exhibit the JAK2 mutation. Next, essential thrombocytosis, some will exhibit the JAK2 mutation. Next, systemic mastocytosis, which is a c-KIT mutation. Next, MPNs associated with eosinophilia, which is the PDGFR-A, PDGFR-B, and FGFR1 mutation. And lastly, the MPNs unclassified. Most will exhibit hepatosplenomegaly due to sequestration or abnormal proliferation of cells, in absence of significant dysplasia. Each of the different subtypes have the propensity to progress to myelofibrosis or blastic transformation. Chronic myelogenous leukemia, CML, case report. 39-year-old man presenting with fatigue, weight loss, night sweats, and early satiety. Spleen is palpable below the costal margin. WBC 78,000 with differential revealing promyelocytes, myelocytes, and metamyelocytes. So we'll see a whole array of the cell line. Hemoglobin 13, platelets 65,000, peripheral blast less than 10%. Remember, will be between 10 and 20% in the accelerated phase and more than 20% in the blastic phase of CML. Appreciable eosinophilia as well as basophilia. Low leukocyte alkaline phosphatase score. BCR-ABL fusion transcript positive on peripheral blood cytogenetics. Bone marrow revealing myeloid hyperplasia more than 10 to 1, normal is 3 to 1, with elevated myeloid to erythroid ratio. In CML, translocation 922 juxtaposes the 3' segment of the ABL oncogene from chromosome 9 to the 5' segment of BCR gene on chromosome 22. The BCR-ABL mRNA translates an abnormal functional protein. The usual transcript is a translator protein of 210 kilodaltons known as the P210 BCR-ABL. Two other transcripts are also possible: the 230 kilodalton protein, which can be seen in chronic neutrophilic leukemia, and the 190 kilodalton protein seen in the de novo ALL. May differentiate between the 230 and the 190 protein by RT-PCR. Very important. The leukemia clone in CML may continue to develop new mutations over time. That is why the time to achieving major molecular response is so important, to lessen the ongoing potential lethal mutations, such as the T359 mutation, which renders the leukemic cells resistant to imatinib and other second-generation BCR-ABL TKIs. If conventional cytogenetics are negative for BCR-ABL, then check FISH, or the most sensitive test is RT-PCR, which can detect BCR-ABL in 1 in 100,000 cells. Even though diagnosis may be made by peripheral blood flow, always important to perform bone marrow biopsy to assess percentage of blasts in marrow. Important to remember, chronic phase CML, less than 10% blasts in the peripheral blood or marrow. In the accelerated phase CML, between 10 and 20% blasts in the peripheral blood or marrow, or the blastic phase, which is more than 20 blasts in the peripheral blood or marrow. Sudden transformation may occur from chronic phase at 1% annual rate per year. In most CML cases, express the P210 BCR-ABL. So, if you're presented with a 922 positive ALL, which is P210 positive, that can actually be CML in lymphoid blast crisis. Milestones that are crucial to know. 1. Achieving a complete hematologic response at 3 months. 2. Achieving at least a major molecular response, MMR, by 12 months. That means Philadelphia cells less than 0.01% or 3 log reduction in PCR clones via PCR. 3. Achieving a complete cytogenetic response via bone marrow conventional cytogenetics by 18 months, so no Philadelphia cells. These milestones are not achieved, especially not achieving complete cytogenetic response in 18 months, either increased dose of imatinib or change to second-generation BCR-ABL TKI inhibitor. Once complete cytogenetic response is achieved, then increase in Philadelphia clones measured via peripheral blood PCR with 2 serial measurements warrants bone marrow biopsy to assess bone marrow cytogenetics, again to see if Philadelphia clones are increasing. Treatment 1. Small molecular TKI. First generation small molecule TKIs imatinib binds to the adenosine triphosphate binding site in the catalytic domain of the BCR-ABL oncoprotein and inhibits the BCR-ABL TK activity. Standard dose is 400 milligrams a day, but can achieve higher molecular response with 600 or 800 milligrams daily. There's also more side effects. IRIS trial. First, phase 3, imatinib versus interferon Talebi. Imatinib was superior in overall survival. Caveat: those who achieved major molecular response had a much lower chance of relapse than those who had not. The second generation small molecule TKI acquired resistance to imatinib is due to point mutations that affect the TK binding domain. Second generation TKIs inhibit most but not all imatinib resistant point mutations. Doses dasatinib 100 mg daily or nilotinib at 400 mg POBID. So far, none of the second generation TKIs have had activity against the T59 mutation. Must know this. May also be more effective than imatinib in cytoreduction of CMML cells in accelerated or blastic phase. If patient loses complete cytogenetic response or major molecular response, then check the ABL kinase mutation for the 359 drug resistance. Third generation TKIs are under development and may act against the T359 mutation. If patient has developed the 359 mutation, for now may attempt cytoreduction with interferon and cytarabine in anticipation of an allo stem cell transplant. Again, allo stem cell transplant may be considered first line in children or adults with progressive accelerated or blastic phase while in TKI treatment or with a T359 mutation. Chronic neutrophilic leukemia. Case report. 55-year-old man presenting with early satiety discovered to have splenomegaly. WBC 26,000 with differential revealing 80% neutrophils and no circulating immature granulocytes, blasts, eosinophils, or basophils. Hemoglobin 13, platelet count 150,000, normal cytogenetics with negative BCR-ABL FISH or PCR. Bone marrow biopsy revealing increased neutrophil counts, negative infectious workup. In chronic neutrophilic leukemia, bone marrow biopsy usually reveals myeloid to erythroid ratio of more than 20 to 1, as we know normal is 3 to 1. There's no increase in blasts, but with clonal evolution, they reach blastic phase within 1 year. So eventually lead to anemia, thrombocythemia as well, and occasionally may be BCR-ABL or JAK2 positive. Treatment: hydroxyurea or interferon to cytoreduce. Splenectomy may actually make neutrophilia worse in patients with splenomegaly, and allogeneic stem cell transplant may be curative in young fit patients. Systemic mastocytosis. 74-year-old man presenting with anemia, leukopenia, fever, flushing, diarrhea, dyspepsia, GERD, pigmented macules on the chest, urticaria, and dermatographia due to increased histamine. No hepatosplenomegaly. WBC 16,000 with 80% lymphocytes, elevated LDH, and elevated tryptase levels. Bone marrow with increased mast cells. Skin biopsy confirms systemic mastocytosis. Systemic mastocytosis is diagnosed by identifying extracutaneous tissue mast cell infiltrates. Bone marrow is most commonly involved extra skin tissue. Special stains for tryptase confirm the diagnosis. Also check serum tryptase levels as they will be elevated. Most cases are due to somatic mutation of the aspartate 816 variant of c-KIT gene mutation. Very important to know. Treatment: antihistamines for symptomatic relief, topical steroids, phototherapy, avoid precipitating factors, and very important, no responses have been seen with imatinib and c-KIT mutations. Lithium. Case report. 56-year-old patient with bipolar disorder on a quote-unquote medicine presenting with neutrophilia. What is the medicine? Lithium increases hypoxia-inducible factor 1, HIF1 alpha, production and causes increase in CXC12 production, resulting in neutrophilia. Chronic myelomonogenous leukemia, CMML, case report. 6-year-old female presenting with lymphoproliferative pain, splenomegaly, and WBC 45,000 with 60% monocytes. Bone marrow with increased monocytes and myeloblasts, translocation 512 positive. CMML is a clonal disorder of hematopoiesis cells carrying features of both myelodysplastic syndrome and myeloproliferative disorder, which predominates in elderly patients, usually BCR-ABL negative. Small percentage of CMML patients exhibit translocation 512, which fuses the TEL gene to the PDGFR and may respond to imatinib, which inhibits the PDGFR-B. Treatment in young fit patients, allogeneic stem cell transplant. In elderly, hydroxyurea or 6-mercaptopurine or hypomethylating agents such as azacitidine or decitabine. Juvenile myelomonocytic leukemia, case report. 20-month-old boy with progressive skin rash, distended abdomen, decreased activity without fever, multiple cafe au lait macules, that's a very important keyword, palpable liver edge, and massive splenomegaly. WBC 24,000 with elevated absolute monocytes, hemoglobin 8, platelet count 49,000, marrow with increased myelomonocytic cells. Males develop JMML in context of neurofibromatosis type 1, therefore cafe-au-lait spots or Noonan syndrome. Hallmark of JMML is a selective pattern of hypersensitive growth and response to the growth factor of GM-CSF. BCR-ABL usually negative, monosomy 7 is common. Treatment prognosis is very poor and may require an allogeneic stem cell transplant. Chronic eosinophilic leukemia. 35-year-old man presenting with fever, weight loss, leukocytosis, eosinophilia, constrictive pericarditis, very important keyword, peripheral neuropathy, cerebral infarction, pulmonary infiltrates, urticaria, and erythematous plaques. Chronic eosinophilic leukemia is caused by constitutive activation of PDGFR-A, PDGFR-B, and FGFR1 gene. PDGFR-A is on chromosome 4, in which a deletion in 4q12 leads to juxtaposition of FIP1L1 and PDGFR-A, leading to deletion of the SHIC2 gene. Very important to know. This leads to bone marrow and peripheral blood eosinophilia. Will present as mostly systemic disorder. Must know endomyocardial fibrosis will result in restrictive cardiomyopathy. Immunophenotype expression is CD23 positive, CD25 positive, and CD69 positive. There's only a minor progression rate to AML. Treatment, imatinib. PDGFR-B and FGFR1. Myeloneoplasms associated with PDGFR-B rearrangement. Located in a long arm of chromosome 5, resulting in ETV6 PDGFR-B fusion. Usually presents as chronic myelomonocytic leukemia, CMML, with associated eosinophilia. May present as skin manifestations of splenomegaly. Treatment, imatinib. Myeloneoplasms associated with FGFR1 rearrangement, formerly known as the 8p11 Myeloproliferative syndrome or 8p11 stem cell syndrome. Patients will present with leukocytosis, lymphadenopathy, splenomegaly, and weight loss. Treatment, allogeneic stem cell transplantation, since lack of response to imatinib and very poor prognosis. Essential thrombocythemia, ET. 56-year-old female presenting with abdominal pain and discovered to have splenomegaly. She's also been complaining of headaches and burning of her hands, erythromelalgia. Experienced a TIA last month. She's had 2 miscarriages in the past. CBC reveals platelet count of 1 million, WBC 13,000, hemoglobin 10, normal iron indices, must rule out iron deficiency as cause of thrombocytosis. Peripheral smell revealing large, dysplastic appearing platelets and occasional eosinophils. Bone marrow biopsy revealing proliferation of megakaryocytes without proliferation of RBC or WBC cell lines. JAK2 mutation is positive. Women with ET outnumber men. Megakaryocytes and their platelet progeny have receptors for thrombopoietin, referred to as the CMML receptors. Erythromelalgia is caused by platelet-mediated arterial inflammation. Thrombopoietin plasma binds to CMML on the surface of circulating platelets. When the platelet count rises, Reduced levels of free thrombopoietin slow megakaryocytopoiesis. Thrombopoietin levels are also elevated or inappropriately normal in clonal thrombocytosis, but in this case, the mechanism involves abnormalities in the regulation of CMPL receptor-mediated uptake of constitutively synthesized thrombopoietin. Morbidity usually results from thromboembolic events and less commonly hemorrhagic events. JAK2 mutation is positive in 50% of cases. Patients with AT often exhibit increased platelet aggregation qualities, hence more thrombosis. And the vasomotor manifestations are due to platelet endothelial interactions. They are 3 times as likely to develop a thromboembolic event, arterial or venous. If the platelets rise above 1.5 million, then the patient actually has a higher risk of bleeding due to acquired von Willebrand defect, as the platelets saturate the von Willebrand proteins. Diagnostic criteria include 1. Platelet count over 450,000, 2. Bone marrow biopsy with increased megakaryocytes, 3. Not meeting WHO criteria for other myeloproliferative disorders, 4. Demonstration of JAK2 and ruling out reactive thrombocytosis. Bone marrow biopsy to assess adequate iron storage is essential to rule out iron deficiency, as well as the degree of fibrosis to rule out primary myelofibrosis, which may also present as thrombocytosis. In ET, will not see trilineage dysplasia or significant marrow fibrosis. Important to rule out 5q deletion myelodysplastic syndrome, as it may also present as thrombocytosis. If thrombocytosis only and positive for BCR-ABL, then treat as atypical CMML. Expect worse prognosis if patient is over 60 and has diabetes, more vasculopathic. It also prevents a secondary AML as the day gets past in this disease. The risk stratification in patients with ET, low risk, age less than 60, no cardiovascular risk factors, platelet count less than 1.5 million and not bleeding, no history of thromboembolism. High risk is patients more than 60 with history of thromboembolism, and intermediate risk is between the two. Treatment, hydroxyurea to decrease platelet count less than 500,000, negrolide, but has been proven to be inferior to hydroxyurea in the PT1 trial with increased arterial thrombosis, bleeding, and marrow fibrosis. Also add low-dose aspirin if patient is in high-risk group. Higher dose aspirin will increase risk of bleeding. Interferon alpha in pregnant women, and if progresses to significant myelofibrosis or AML, consider allogeneic stem cell transplant in younger fit patients. Polycythemia Vera, case report. 55-year-old man presenting with headache, chest pain, and early satiety. Hemoglobin 18 with elevated RBC mass. WBC 13,000 and platelet count of 760,000. Palpable splenomegaly on exam and occasional basophils on peripheral smear. Erythropoietin level very low. Hemoglobin oxygen saturation normal. Bone marrow biopsy revealing erythroid and megakaryocytic hyperplasia with reticulin fibrosis. JAK2 V16F mutation positive. P-Vera is defined as elevated RBC mass without hypoxia or excess erythropoietin production. Since it's a multipotent stem cell defect, usually we'll also appreciate thrombocytosis and leukocytosis in addition to the erythrocytosis. Remember, if the clinical vignette is of a familial erythrocytosis, think of high-affinity hemoglobin defect or the familial polycythemia, Juvenile Russians with abnormal erythropoietin receptor. PP is caused by the somatic mutation in codon 617 in the JAK2 tyrosine kinase, which results in constant activation of tyrosine kinase independent of erythropoietin. If JAK2 V16F is negative, then check JAK2 exon 12 mutation. But if that's also negative, it does not exclude P-Vera. Could present as a hypercoagulable state, large vesicle thrombosis, so think of P-Vera in unusual thrombotic situations, for instance, dural sinus thrombosis. May also present with Budd-Chiari, and many have the JAK2 mutation. May be tricky as these patients are fluid overloaded, so may exhibit relatively normal hemoglobin due to a fluid overload state. Not only can the patients be plotters, both arterial and venous, but they can also be bleeders while on aspirin. Very important, the higher the WBC count, the higher the risk of thrombosis. Diagnostic threshold is hemoglobin more than 18.5 grams in men and 16.5 in women. Be certain that it is not a secondary cause of erythrocytosis, such as chronic hypoxia, erythropoietin-secreting tumor, obtain renal level ultrasound and a head CT rule out a hemangioma, or exogenously administered erythropoietin or androgens, such as in athletes, sleep apnea, elevated carboxyhemoglobin levels, or oxygen dissociation curve to a lot high-affinity hemoglobinopathy. Also, post-renal transplant patients presenting with erythrocytosis, treat them with ACE inhibitors or ARBs. Polycythemia is of concern as it may cause hyperviscosity, so consider phlebotomy of hematocrit more than 45%. Remember to replace RBC removed with normal saline. A significant number will progress to myelofibrosis, an end-stage condition called post-polycythemic myelofibrosis, which is characterized by hepatosplenomegaly, extramedullary hematopoiesis, myelofibrosis, and pancytopenia. It may transform to AML. Remember, Shuvak-type polycythemia seen in the Russian Shuvak population and caused by mutations in von Hippel-Lindau gene, leading to defective oxygen sensing and secondary erythropoietin overproduction. In F Vera, the erythropoietin will be low. That's how you differentiate the two. Treatment, phlebotomy, to keep hematocrit less than 45% in men and less than 42% in women, and less than 37% in pregnant women. Myelosuppressive therapy with hydroxyurea. Remember, the lower the WBC count, the less likely the chance of a thrombotic event. Or interferon 5 million units 3 times per week. Thromboprophylaxis with aspirin 81 mg daily, but remember, there's also increased risk of bleeding. High-risk patients more than 60 years old with previous thrombotic event should be on hydrea and aspirin as well as phlebotomy regimen. In terms of operations, achieve normal hematocrit with phlebotomy and platelet count less than 400,000 with plateletpheresis if necessary, preoperatively and postoperatively to risk post-op or pre-op complications. SSRI, PUVA, or antihistamines for the pruritus. In pregnant women, phlebotomize to keep hematocrit less than 37% to decrease hyperviscosity risk to the fetus, and cytoreduce with interferon and not hydroxyurea, unless teratogenic, and daily aspirin. If hydroxyurea not an option, then interferon will control blood count and possibly decrease splenomegaly. You may consider alkylating agents such as busulfan or chlorambucil if conventional therapies are ineffective. An allogeneic stem cell transplantation in young patients may potentially eradicate the F Vera clone or secondary leukemia with antecedent F Vera. This concludes the myeloproliferative chapter. Thank you.